Good afternoon, everyone. It's my great pleasure to introduce our next speaker, Dr. Kathleen Job. Dr. Job is a recent research assistant professor in the Department of Pediatrics at the University of Utah, where she also earned her PhD in bioengineering. She's a board-accredited clinical pharmacologist with over 15 years of experience, and her areas of clinical research expertise include the use of drugs and devices in special populations with the focus on integrating physiology and pharmacology into approaches for designing, conducting, and interpreting clinical trials to better understand drug disposition through from conception through adulthood. She also currently has NIH K-23 funding to study asthma drugs during pregnancy. Please join me in welcoming Dr. Kathleen Job.
Thank you for the opportunity to speak today. I appreciate the chance to participate in this year's MPRINT meeting. I've been looking forward to it for a couple of months now. Today, I will discuss the use of Rivaroxaban during lactation, focusing specifically on how relatively small data sets combined with modeling approaches can address persistent dosing and labeling gaps for postpartum patients. To provide context, I will first briefly outline the problem, then focus on Rivaroxaban as a useful example. Specifically, I will present our approach to understanding infant exposure, which involved a pilot study and combined it with non-compartmental analysis and population and physiologically based pharmacokinetic modeling. With this in mind, I will begin by considering the broader context. We know medication use during pregnancy and lactation is very common. About 60% of pregnant moms take medications for pre-existing conditions or pregnancy-related conditions. This number goes up to 70% of lactating moms taking prescription medications. However, the majority of these drugs lack adequate labeling during lactation. Importantly, this gap often reflects not known harm, but much more often reflects missing data. This lack of data creates uncertainty, which often leads to conservative clinical decision-making that may not always serve the patient's best interest. Anticoagulation during the postpartum period is a really good example of this. Venous thromboembolism remains a major public health issue. In fact, as many as 900,000 people in the United States each year have to deal with this. Postpartum moms are particularly high risk, making pharmacologic thromboprophylaxis an essential component of care. Heparin was first discovered in the early 20th century, but it was not until really the 1940s that warfarin, vitamin K, and heparin therapy became available for thromboprophylaxis. Over the past 15 years, thromboprophylaxis has increasingly moved towards direct oral anticoagulants, or DOACs. These drugs inhibit factor Xa. They have predictable exposure and are much more convenient for patients. Rivaroxaban is one of the earliest and most widely used DOACs. In non-pregnant adults, it is considered a first-line therapy for preventing recurrent deep vein thrombosis. However, postpartum practice looks quite a bit different. Despite widespread adult use, guidelines continue to recommend heparin-based therapy during lactation. Importantly, this recommendation is based on uncertainty rather than demonstrated harm. And Rivaroxaban is not recommended during lactation due to insufficient data on maternal exposure and transfer into breast milk. This disconnect serves as the motivation for the present work, and it leads to our more focused discussion on Rivaroxaban. From a clinical perspective, Rivaroxaban is a very appealing drug. It's administered orally, it acts rapidly, and requires minimal monitoring. The primary challenge during lactation is infant exposure, though. We know that Rivaroxaban is excreted into human milk. The unresolved question is whether the amount transferred to the infant from milk actually makes a difference. Is it going to harm the baby? This leads directly to the central question. is how much is an infant actually exposed to? This question has been formally recognized at the national level. In 2024, NICHD convened a stakeholder meeting to prioritize research needs in pregnant, postpartum, and lactating individuals. One clear conclusion was that there's insufficient data to determine the effects of Rivaroxaban on the breastfed child or even on milk production. Importantly, this was framed as an absence of evidence, not evidence of harm. From that meeting emerged several more specific unanswered questions. The first is whether it is safe and effective during the postpartum period to take Rivaroxaban. Most PK and outcome data come from non-pregnant adults, yet postpartum moms are routinely treated using standard adult dosing. This creates uncertainty before even considering lactation, and that uncertainty extends to PK. A closely related assumption is that postpartum PK and pharmacodynamics mirror adult observations, and adult PK parameters are often applied directly to postpartum moms despite limited data. Uncertainty in maternal exposure makes the downstream assessment of infant milk even more difficult, or infant exposure even more difficult. This brings us to milk transfer. Rivaroxaban has been detected in human milk, but prior reports consist of small case studies with limited sampling, and as a result, the magnitude and variability of milk transfer remain poorly defined. And ultimately, this leads to the clinical question that matters most. If Rivaroxaban enters human milk, does that exposure pose a meaningful risk to the nursing infant, especially bleeding risk? Without reliable infant dose estimates, that question cannot be answered objectively. This is where PK data and modeling become helpful and even essential. To answer that question, we first need to define how infant exposure is typically evaluated. When clinicians and regulators think about lactation safety, 3 metrics usually drive that discussion. The first is the milk to plasma ratio, which describes relative partitioning of a drug. The second is daily infant dose, or DID, which estimates absolute exposure. And the third is relative infant dose, or RID, which contextualizes infant exposure. And this is relative to the maternal dose. An RID below 10% is often used as a low-risk benchmark, although it is an imperfect threshold. With that framework in mind, I will walk through our pilot study. When the NICHD meeting occurred, Dr. Ann Bruno from the University of Utah and I had already begun studying Rivaroxaban exposure and transfer into human milk. This pilot study was funded by the Foundation for Women and Girls with Blood Disorders and also a 2023 pilot award from the University of Utah Clinical and Translational Science Institute. We enrolled 20 lactating postpartum moms receiving prophylactic Rivaroxaban, and prophylactic Rivaroxaban is 10 mg once daily. Participants temporarily refrained from breastfeeding to fully characterize drug concentrations without direct exposure to the infant. Ultimately, we collected paired plasma and milk samples along with samples to characterize metabolizing enzyme activity. And here, our goal was to quantify exposure. However, before looking at exposure, I want to talk about the demographics of the population that we enrolled. The 20 enrolled postpartum moms had a mean age of 32 years and a mean BMI of 31, and this reflects populations commonly receiving postpartum thromboprophylaxis. One important feature of this cohort is the wide range in time after delivery. Participants range from less than 1 day to over 500 days postpartum. This range allowed us to evaluate exposure across different postpartum time points rather than treating postpartum as a single state. Our population is fairly uniform, and most participants self-identified as white and non-Hispanic. So importantly, we were able to collect temporally matched plasma and milk samples for each participant, which allowed us to determine milk to plasma ratio. So with this study population defined, we first focused on overall exposure, and we evaluated exposure using 3 metrics. We started with non-compartmental analysis because it provides transparent, assumption-light summary of exposure in plasma and milk. Using these NCA methods, we estimated area under the curve, AUC, and average concentrations in both plasma and milk following a 10 mg dose. The figure on the left is concentration time curve of maternal plasma, and the figure on the right is the concentration time curve for milk. I want to point out that the x-axes are the same, but the y-axis scales are different. So for plasma, it goes from 0 to 400 nanograms per ml, and for milk, it's 0 to 200 nanograms per ml. From these values, we calculated the milk to plasma ratio, daily infant dose, and relative infant dose. And the milk to plasma ratio was 0.45, and the median RID was 2.9%. And 2.9% is well below the commonly cited 10% threshold. At the population level, these results suggest low infant exposure. However, averages alone do not tell the full story. When we examined exposure across the specific time points that we collected, the absolute infant dose remains small even at peak milk concentrations. A typical infant anticoagulation dose is about 0.9 mg per kilogram per day, while the typical adult Rivaroxaban dose is actually lower at 0.14 mg per kg per day. However, even at the maximum observed milk concentrations, the estimated infant doses remained only a small fraction of the therapeutic infant dosing. That said, there was substantial inter-individual variability, and this led us to ask whether that variability could be described more systematically, rather than treated as unexplained noise. To explore this question, we turn to population PK modeling. Pop PK modeling allows us to quantify variability and evaluate whether identifiable covariates help explain differences in exposure, even in relatively small data sets. Before showing our postpartum model, I would like to review what's already known. Pop PK models of Rivaroxaban have been developed in multiple adult populations. Across these studies, clearance and exposure are influenced by covariates such as renal function, genetics, and disease state. Structurally, these models use 1 and 2 compartments with first-order absorption and elimination. Notably, these models do not include postpartum status nor milk concentrations because they weren't looked at. So what we did was apply a similar POT PK framework to our postpartum data. We developed a 2-compartment population PK model that included both plasma and milk. Most observed concentrations fell within the prediction intervals, suggesting reasonable model performance given the data set size. 2 covariates that were statistically relevant were time after birth and CYP3A5 status. When we examine these covariates, time after birth emerged as a source of variability for apparent clearance and for apparent volume of distribution in the plasma compartment, and then also transfer to the milk compartment. It was a factor 4. Stratifying the observations by time after delivery showed systematic changes in exposure and model parameters, especially among moms closer to delivery. The most pronounced differences appear in the early postpartum period, where concentrations and parameter estimates show greater spread across moms. As time after birth increases, exposures stabilize and resemble those in what I would imagine would be typical for an adult population. From a population modeling perspective, this suggests that treating all postpartum moms as pharmacokinetically equivalent may not be appropriate, especially during this early time after delivery. Another key point here is descriptive. Time after birth captures meaningful variability in exposure, but what I want to now do is compare our postpartum population model to existing adult models to highlight some of this. Compared with adult models, estimated clearance was somewhat higher in this postpartum cohort. The takeaway here is that postpartum exposure is not identical to adult exposure. However, POP-PK alone cannot predict unobserved scenarios or test mechanistic hypotheses. This POP-PK model describes how exposure changes with these covariates, but it does not explain why those relationships exist. In other words, its purpose is to identify patterns and variability, not mechanisms. That distinction becomes important when we move to physiologically based modeling. Because clinical data in lactation are limited and we wanted to explore scenarios beyond our observed data set, we developed a physiologically based PK model. This allowed us to explicitly incorporate known drug properties and biological processes. Before presenting our PBPK model, I wanted to acknowledge the limited but very valuable data existing for lactation for Rivaroxaban. Before this year, there were 6 reported case studies evaluating therapeutic dose Rivaroxaban. And typically this is 15 to 20 milligrams once daily, and this was in lactating moms. Across these cases, Rivaroxaban was consistently detectable in human milk with estimated relative infant doses ranging from approximately 1.3 to 5% of the maternal weight-adjusted dose. Importantly, even at therapeutic dosing levels, these relative infant doses remained below commonly referenced safety thresholds, so the 10%. And there were no adverse events reported for these infants. Building on these data, Butler and colleagues recently developed a physiologically based pharmacokinetic model to describe Rivaroxaban transfer into human milk, and they were able to validate that for the 15 and 20 mg doses. If we look at this, so the top row here is for the 20 mg once daily dosing, and on the left is the plasma concentrations, on the right is the milk concentrations. The bottom row similarly is for 15 milligrams once daily dosing. And ultimately we can see this is a pretty good model. Most of the dots are within the shaded areas. And really this effort represented an important advance because it moved beyond descriptive metrics and provided a mechanistic framework for understanding milk transfer. However, that model has several limitations relative to our work. First, it could not be validated for the 10 mg once daily prophylactic dosing. And second, the model lacked data on metabolizing enzymes and transporters, which limits its ability to explore inter-individual variability in milk concentrations. These gaps informed our decision to develop a PBPK model that incorporated postpartum physiology as well as enzyme activity and used our data from our pilot study. To do that, we started from what is already well established about Rivaroxaban's pharmacokinetics. Rivaroxaban is actually a pretty good candidate for mechanistic modeling because its ADME properties are relatively well characterized across multiple populations. From an absorption standpoint, Rivaroxaban has high oral bioavailability, particularly at the 10 mg dose, where bioavailability approaches 80 to 100%. This may simplify interpretation of exposure, especially at prophylactic dosing, because variability in absorption is less likely to drive extreme conditions, but it still could. In terms of distribution, Rivaroxaban is highly protein bound and has relatively low tissue penetration with a steady state volume of distribution of around 50 liters. These properties suggest that most of the drug remains in the vascular compartment, which is relevant when thinking about milk transfer mechanisms. Metabolically, Rivaroxaban is cleared primarily by the liver. About 45% of Rivaroxaban undergoes oxidative metabolism, and this is mediated by CYP3A4, CYP3A5, and CYP2J2. There's also an additional fraction that is cleared by non-oxidative pathways. Importantly, CYP3A5 and CYP3A4 exhibit inter-individual variability, both genetically and developmentally, which makes them possible contributors to variability in what we're seeing in postpartum exposure and milk concentrations. For context, over half the participants in our pilot study were normal CYP3A4 metabolizers and poor CYP3A5 metabolizers. Finally, rivaroxaban is eliminated through both fecal and renal pathways. Roughly 35% of the drug is removed unchanged through urine. And this is through a combination of glomerular filtration as well as active tubular secretion. And the active tubular secretion is mediated by ABCB1 as well as BCRP. Variability in these transport mechanisms combined with postpartum changes in renal physiology provides another potential explanation for any higher milk concentrations that we may observe in our moms. With those inputs defined, I will show how our PBPK model performs. Using this information that I've talked about what we know about rivaroxaban pharmacology, postpartum physiology, and the data generated from our pilot study, we then simulated 100 postpartum moms receiving 2 doses of 10 milligrams of rivaroxaban. And what I'm showing you here is results from day 2. On these plots, the left panel shows predicted plasma concentrations, and the right panel shows predicted milk concentrations as a function of time after dose. The solid lines represent the median predictions, and the shaded regions represent the 95% confidence intervals from the model. Importantly, we overlaid the observed data from the 20 study participants on top of our simulations. Overall, the model does a pretty good job. About 70% of the observed concentrations fall within the 95% prediction intervals, which seems reasonable performance given the sample size and the heterogeneity of the postpartum model. And I'm pretty happy with the AFE and the AFE below 2. Looking at the exposure metrics more broadly, the predicted AUCs, maximum concentrations, and time to maximum concentrations align well with what has been reported in adult studies and with previously published simulations at the 10 mg dose. In the next 2 slides, I'll show you these results. But I want to point out that this all gives us some confidence that at least at the population level, the model is capturing rivaroxaban disposition in postpartum moms reasonably well. That said, you will notice a small number of points that fall outside the prediction interval, particularly at the upper end of the milk concentrations. We are actively considering this and welcome any thoughts that you may have on additional mechanisms or covariates that might explain these higher than predicted results. If you have any ideas, I would love to talk more about them after my presentation. So to put these predictions in context, we first compared them directly to adult data. Mean postpartum AUC and Cmax values fall within ranges reported by MUIC under fed and fasted conditions, and the upper ranges were only slightly higher than those observed in fasted adults, and the half-life tended to fall near the lower end of the adult ranges. Overall, systemic exposure in postpartum moms at 10 milligrams dosing appears broadly comparable to that in adults. We also compared our simulations to prior PBPK work by Butler and colleagues. Our simulations also agreed with the 10 mg daily models by Butler and colleagues. Plasma exposure metrics were very similar, and the overall shape of the milk concentration time profiles aligned well with the Butler PBPK model. And the data that's on the right of each panel, so that's our simulations. One difference worth noting is that our model predicts slightly higher milk concentrations compared with the Butler simulations. Importantly, these differences are modest and still yield relative infant doses that remain low in absolute terms. To further stress test our model, we also simulated higher rivaroxaban doses, and what we saw was comparable to the treatment level dosing that Butler predicted. At higher simulated doses, therefore, we are also fairly confident in our model. Overall, up till now, these results have given us confidence in the model's behavior across various dosing scenarios. So once we felt comfortable with our model, we used it to explore the impact of metabolism and transport variability on rivaroxaban exposure. Here we simulated 3 scenarios: normal metabolism, and poor metabolism combined with decreased transporter activity. As expected, moving from normal to poor metabolism results in higher predicted exposure in both plasma and milk. And this is reflected in increases in both AUC and Cmax. When we further reduced transporter activity, particularly renal transport, we saw an additional increase in exposure. And importantly, even under these more extreme scenarios, the absolute milk concentrations remained relatively low, and predicted infant doses stayed well below therapeutic levels. These simulations reinforce that known variability in metabolism and transport can contribute to higher concentrations, but they still were not able to fully explain the highest observed values in our data set. One covariate we wanted to take a closer look at was CYP3A5. In this analysis, we compared model predictions specifically for moms with slow CYP3A5 metabolism. As shown here, reduced CYP3A5 activity is associated with increased exposure in both plasma and milk, and the model does a reasonably good job of predicting the magnitude. However, there's still points that are outside of our 95% confidence interval. So really, this just ultimately reinforces that we do need additional data. And I just want to close with some of those thoughts. These data highlight the need for additional studies to better characterize exposure and response in lactating moms and infants. Practical question is whether infant exposure during breastfeeding should preclude study participation. And based on the current evidence that we have and that we've looked at here, I would argue that it should not. Even at worst case milk concentrations, estimated infant doses were below that 10% threshold, and often for prophylactic dosing, they were around 2% of a maternal dose. This is consistent with LACMED and published case reports, none of which report adverse infant events. So therefore, allowing breastfeeding in carefully designed future studies, I think, is reasonable and necessary to move beyond that uncertainty. Before I conclude, I need to acknowledge the people groups and funding sources on this slide. They've all been pivotal for accomplishing this work and research, and ultimately for my support. Thank you, and I would love to take any questions.
Hi.
Hi.
Thank you so much. Very interesting talk. I'm Tamara Lewis, a pediatrician and clinical pharmacologist from Sick Kids. My question is about the planned future pharmacodynamic endpoints in the infants. So it's good to hear that the relative infant dose is relatively low, but do you guys plan to perform any kind of like clotting assays in the infants to understand changes in clotting capacity? And the reason this becomes really important is because more parents are declining the vitamin K injection at birth. So more neonates are already being placed at hemorrhagic risk, and we counsel new parents about the risk of declining vitamin K, but I'm very interested in sort of like the combination of a family that's declined vitamin K and a mom that might be taking an anticoagulant.
Thank you. That is an excellent question. And right now we're looking at what might be most appropriate markers for PD in our infants. Usually it's more general and not that specific that yes, adverse event, yes, bleeding, but I think that recommendation, is one that we can definitely look at. Our moms at University of Utah are typically pretty good with allowing us to take infant blood. But I would love to talk to you more about what would actually be the best markers and to help give confidence to our studies.
Hi, I'm Sarah Coggins. I'm a neonatologist at the Children's Hospital of Philadelphia. And I was super interested by your data and thinking to myself about sort of the safety calculus of giving Rivaroxaban exposed maternal milk to extremely preterm infants who are sort of the highest risk of hemorrhage and for whom the least data exists. And I'm also curious because we know that the composition of breast milk changes at say the 24-week range versus the term range. Like we know there's a lot more protein in fat in preterm breast milk, and just wondering if you could speculate as to whether these data might still hold true in, say, a mom pumping at 24 for a 24-week gestation baby, and whether rivaroxaban transfer might change in that scenario.
I absolutely think that milk, that there will be a factor for those youngest babies. And I do think, I mean, for those youngest babies, I'm getting good colostrum, like that directly affects outcomes for these babies. I mean, if we were designing the study, I probably would not include those youngest babies at the beginning. I mean, we don't want to challenge them anymore, but for healthy situations that are a little bit outside of that most risky window, I think that's probably where we're headed with our studies. So yes, I think that there are definitely more considerations for our at-risk, very at-risk babies.
Hello, Amparo de la Peña from Simulations Plus. And my asked half of my question already, but it was about fat content of the milk, because Rivaroxaban is quite insoluble in water, but it seems to be more polar, so more soluble in fat, and we know how milk composition changes with the life of the infant. So I was wondering, do we have data to know what is the correlation between age since birth and fat content in the milk? Is there a direct relationship so that using just the age would account as a sufficient covariate, or would we have to look at fat composition, and do we have that data?
So that's an excellent question too. One of the hardest things about, so in Utah, we have plenty of moms that want to donate milk, but oftentimes everything gets grouped into one lump sum. So I think there is variability in fat content for each mom, and depends on a number of factors that happen that make it difficult. For this data set, we did not have all of that information, but it would be, so rivaroxaban tends to be it's moderately lipophilic. So drug passage would change. And with our milk to plasma ratios in the data set, I mean, it ranged from about 0.16 to about 0.8 for some of the moms, which, I mean, it could explain some of that. We had only about, I think, 2 or 3 of our participants were within that first week or 2 of birth. So most of our data is actually past that 2-week period, when there's quite a bit of a change that happens in breast milk. So we're working on getting that data, because that's critical to understand for studies like this. Thank you.
Tom Callahan and IU. I was curious, with the ASH guidelines, the suggestion is apixaban in relationship to rivaroxaban, that apixaban seems to be less likely to cause bleeding. Is there any data to suggest, or do you have any feeling that apixaban could be safer, or has anybody studied the comparison?
So yes, I think that's one thing that's been looked at. There has been some apixaban data, and that was actually, so Butler looked at that. It actually transfers more into the milk. So the thinking is that rivaroxaban, it transfers like 0.45, and if I remember right, apixaban is like 1, I forget exactly what it is, but it's over 1. And so the thinking is that rivaroxaban might be the better drug to look at.
Thank you very much.
Mm-hmm.